Hello, everyone, and welcome to today's webinar. My name is Aninjanja, a communications specialist at Center for Epidemiological Modeling and Analysis, SEMA. And I'm honored to be your moderator for this session. So today, our speaker will address a critical challenge here in Kenya and across different countries in Africa, which is visceral leishmaniasis. You can call it VL or Kala-azar. Kala-azar is more than just a neglected tropical disease, it's a recurring crisis. Just last year, Kenya faced a surge with over 3,000 known infections recorded in the first 6 months alone. Sadly, lives were lost too, 80 of them to be precise. Most of them children under 5 in regions like Marsabit, Wajir, and Turkana. These outbreaks underscore that Kala-azar is a deadly reality that also exposes deep inequalities in our healthcare access. Therefore, to move from reactive crisis management to sustainable elimination, we must bridge the gap between field data and predictive science. Joining us to discuss this is Dr. George Paul Omondi, a senior research fellow here at SEMA. George is a vet who studies the links between animal and human health. Before I leave the floor to our speaker, please note that the session will be recorded and will be available on our YouTube channel later. Also stay muted, but we encourage engagement, so please use the chat for that. Post your questions in the chat at any time, but we have a Q&A session at the end where they will be addressed. Without further delay, Dr. George, the floor is yours.
Thank you so much, Annie, and good afternoon all, and welcome to today's seminar series, which is targeting visceral leishmaniasis and thinking around elimination. This work has been carried out in consultation or in collaboration with a lot of other different organizations that I'll acknowledge at the end. This is part of working together as SEMA with the different ministries and the different both animal and livestock to basically use data to advance health in Africa. So visceral leishmaniasis as a parasitic disease basically is caused by leishmania, and it's really prevalent in a few parts of the world. There's about 50,000 to 90,000 cases annually, and it's fatal if untreated. Unfortunately, it does affect the poor, those who are really marginalized, and those in endemic areas basically are isolated. What we see is a map that basically shows Africa in terms of which countries and which countries previously reported. But of note is there are very few countries in the world that contribute approximately 80% of the global burden. This includes Brazil, Kenya, Ethiopia, India, but has declining, Somalia, South Sudan, and Sudan. There are other pockets, especially where we have, especially within East Africa, which contributes approximately 70% of the cases. And here we have Kenya as well, Ethiopia, South Sudan, Somalia, and Uganda. So the question then is, why do we have visceral leishmaniasis? Why does it occur? And how can we work on it? Considering that it affects the most marginalized in the community. So here we have different types of leishmaniasis. There's cutaneous and there's the most common, cutaneous and visceral. And here is a global map from a paper just released recently by Parain in Nature Reports. And they're basically showing a global map of leishmania and the overlapping endemicity between cutaneous and visceral leishmaniasis, especially in East Africa, that is Ethiopia, Sudan, but also in Kenya. I'll show a map in a short while. South Asia, Brazil, and the Mediterranean and Middle East. What we need to remember is this is a vector-borne disease, and so the ecology plays a very big role in sustaining the vector. This is the phlebotomers, female phlebotomers that actually cause the infection or transmit the infection. So because of the similar ecologies, we basically have a co-circulation of the Leishmania species. As a brief historical context in Kenya, Leishmania was first reported in Mandera and Wajir back in 1935. In the 80s and 90s, it was basically reported in Rift Valley. So we're talking about the Baringo, the West Pokot. And then in the 2000s, we started having new foci emerging. So these include other areas, including Turkana. And then over the last 9 years, give or take, we've started seeing other new foci, Kitui, Tarakaniti, a few cases, especially in Meru, but we have new outbreak areas like Kajiado and Samburu. As I've mentioned before, the thing to remember is the ecology plays a very big role. 80% of Kenya is a rangeland, which means it has similar ecologies. There are differences, especially with respect to edaphic, this is the soil, but also the climatic and the environmental variables, the trees and stuff. So the ecological drivers here basically support the disease being in the arid and the semi-arid areas. These include things like termite mounds and vertisols. And then, as usual, the climatic expansion, which is leading to somewhat downward trend, but also you have places like Kajiado, and it's important to remember that.
1, 2, 3.
Sorry about that.
Similar ecologies in places like Narok, in places like Isiolo has similar ecologies with parts of like Meru, and then you have Kitui with similar ecologies to parts of like Garissa. And then we also have housing, especially the manyatas and the environment, the livestock, and also the large number of dogs. And because of the wildlife we have, especially the hyraxes, we also are starting to think about the potential for anthropootic transmission. Anthropoosis is basically the transmission of disease from animals to humans, but also backwards. The peak is rainy season, and I'll show you that. The graph you're seeing on the left basically is an epicurve. An epicurve is basically a curve showing the epidemic from 2011 to 2025. And you can see we've been having more cases. But the thing to remember is there's more cases, but also it might be because there's more effort to identify cases. However, we will explore that a little bit. This is a map of Kenya showing endemicity of both the vectors for both VL and CL. VL is visceral leishmaniasis and CL is cutaneous leishmaniasis. And you can see there's a lot of overlapping areas, but a good chunk of the country is actually has endemicity to the phlebotomous flies, sand flies. The area Bungoma is basically because of the Mount Elgon, but we have other areas coming up. So we do explore epidemiology. At SEMA, we use data to think about health, and how we kind of cascade this thought process is we explore the epidemiology of the disease, and that includes the vector and the human transmission side, but also a little bit of within the human, what is it? Epidemiology, by definition, is study of disease patterns and distributions. And we try to build a framework. A framework here denotes a way of thinking that can be activated to actually control the disease. The aim of epidemiology as a support system for public health is basically to allow for understanding of patterns, to allow for understanding of distributions, and more importantly, to use the insights we gain to basically develop a pathway that we can use to control diseases. So if we say people who drank this kind of water get sick, or people who live in a certain type of area get this kind of a disease, we can start thinking about where is the transmission occurring. We can see maybe children are more affected, or people with comorbidities, malnutrition, HIV/AIDS, TB, and other things like fungal diseases. So who is more at risk? And then why are the cases persisting? Why are they persisting in certain particular areas? Are we having a change in ecology? Are we having a continuous ecology? Are we having a mistiming, for instance, between how we handle cases or how we time cases with the peak seasons? And then how can we control it? So what interventions? For visceral leishmaniasis, we know it's a vector, but also there's the human side. So there's treating the humans. But before you treat the humans, you need to identify who are these particular individuals who are most at risk. For the vectors, where do they reside? What control measures can work? How do you integrate interventions? And what is the efficacy of these interventions? And then we ask how. How do we measure progress? So this whole presentation over the next 35, 40 minutes will basically try to address these particular questions from different angles. So as a basic primer, we try to do a situation analysis of the visceral lesh in Kenya. We have documented cases from the data, and here we're using health facility related data. So these are data that comes from people or patients who visit hospitals and are treated for visceral leishmaniasis. So from the data set, we have about 22 counties, 80 sub-counties, and about 100, representing about 184 wards. However, the important thing to note is only about 13 counties have had a continuous presence of VL from 2017 to 2025, the period within which we have this particular data set. The most high burden counties include Turkana, West Pokot, Wajir, which account for about 68% of the burden in Kenya. The top 5 counties account for about 86.8%. Now, that statistic is important because it tells us that if we are aiming at controlling the disease or eliminating the disease, there are certain areas we can focus on. However, it's important to remember that when you have a very high level aggregation of cases, you miss the granularity, and the granularity is actually what is important to identify drivers of transmission. The graph basically shows you which counties are highest. West Pokot, Marsabit, Isiolo, Baringo are kind of come on the top. And then we have a couple of emerging counties that are coming in there. Samburu is one of them, Kajiado is another one. A reclassification to use the county of residence of the individual visiting a facility. We have about more than around 40, 43 facilities in the country. Brought out Elgeyo Marakwet, which is not a surprise because the ecology is very similar. And what we've done through the whole presentation is we've classified counties, sub-counties, and wards based on the incidence per 10,000 people. So we have high incidence ward, which has more than 15 per 10,000, an incidence of more than 15 per 10,000. Counties, so we can call it, not necessarily, but we can call it a hyper-endemic. We have a meso-endemic, we have a hypo, low endemic, and a non-endemic, which is like less than 1 per 10,000. I will not use the terms meso, hypo. I'll just use greater than 15, 7 to that, and that as we move, characterized by color. At the sub-county level, we see that there are several sub-counties. However, 10 sub-counties account for 65% of the burden. So if we come from the county level, we can actually cascade down to certain administrative units to actually start identifying, and I'll show as we move forward why that is important. In terms of raw cases, Pokot Central contributes about 13% or 14%, Wajir West 10%, Eldas approximately 7.9%. So already, if we can identify a sub-county, we actually would be able to start doing targeted or precision interventions. So by incidence, the top counties are, so incidence basically is number of cases per certain time, and like prevalence, which is basically a snapshot of the number of cases over the number of those who are affected. And so we have Lethamis, Eldas, Wajir West, Merti, Pokot. The thing to note from that graph is the colors. The colors are basically representing the counties within which the sub-counties are. And you'll notice counties like Turkana have so many sub-counties, that are within the top, quote unquote, 20 in terms of burden. And so you'll see some may not be as many, for instance, Wajir West and Eldas, but it means those two counties, especially if you consider the fact that Wajir at an incidence level is extremely high, those two sub-counties, Wajir West and Eldas, may be driving the transmission or the cases there. And so then that may actually warrant an extra level of intervention. At the ward level, which is kind of what we are interested in because it allows us to start locating cases, especially at a very lower level, and then try to correlate the burden of cases and activities, both human, animals, environment, the ecosystem health as a broad principle to think about what interventions can work. So top 20 wards account for about 60% of the cases. This is from 2017 to 2025. However, if you take the from 2023 to now, you will see that there are actually 18 high burden wards that account for about 44% of the cases. The implication for this is we could actually try and have targeted interventions, especially in the high burden wards, and these could potentially impact. When I talk about impact, I mean halving or reducing the incidence or the prevalence in about half of our burden as a country. And so as a basic conclusion for that basic kind of a high level picture, we see that we have about 56 wards that will be considered very high burden, more than 15, an incidence of 15 per 10,000 cases. We have about 18 wards at about meso-endemic, so moderately endemic, but still very high when you're talking about 7.5 to 14.9 per 10,000 cases. Then we have hypoendemic, 2.5 to 7.5, 35 wards. But critically important is we have about 76 wards that are less than 1 per 10,000. So here and then we can talk about having 73 wards, about 33% of our wards requiring intensive intervention if we are to make some progress towards elimination. And I'll explain why I'm talking about progress towards elimination and not elimination per se. This is a map developed by CPE through the data that we have from the Enfant group. And what it shows is at a village level, rather than list the villages, I thought this might be a better depiction, where you have a clear pictorial of as much as, for instance, West Pokot is a problem. If you go to Turkana, there are certain pockets. If you go up in Mandera on the right, top right, there are specific pockets in certain specific environments. And it's important to remember that some of the cases we have in Kenya are actually imported cases from Ethiopia, from Somalia, and from Uganda. And so this kind of granularity allows us to start asking the question, which villages are more important? Where can we do vector surveillance? Because those are the most important places that we could start doing vector surveillance, and that allows us to actually be able to follow the dynamics. And I'll talk about asymptomatic vis-a-vis symptomatic and their contribution to transmission in the country. So the coloring, basically, the heavier the color, we're talking about a very high endemicity of more than 15 cases per that particular village, which means you could see Wajir at a very particular places like Eldas, you could see the Isiolo, you could see the Marsabit, you could see West Pokot being a problem. But then you have other areas that have emerged recently, like Tharaka Nithi and a few in Meru. And then we have Kajiado and a few in Kitui, which allows us to start thinking about a phased or a cascaded intervention plan. Broadly, I will not take a lot of time on this, just to show that out of the cases we have, there seems to be, which is expected with the vector-borne disease, seasonality effect, which is mainly driven by the long range. The dark red is basically the March, April, May long range. And then we have the October, November short range. And then we have the other months that are there. But you see a peak in cases just around the rainy season as it progresses, and then it goes down and comes back up. This is important for targeting vector surveillance, but also preparing for interventions, basically supplies, commodities, and things like that. The important thing to note here is there's about 2 to 6 months lag between the rainy season and the peak in cases when we do a trend analysis, which basically corresponds to the incubation period of visceral leishmaniasis, but can be used to think about how to target surveillance. Here, as kind of concluding the situation analysis, you see on the top left, in Kenya, the Ministry of Health defines visceral leishmaniasis as someone who has a fever of at least more than 2 weeks and at least one organomegaly. Here is either you have splenomegaly, an enlarged spleen, or you have hepatomegaly, which is an enlarged liver. Those who met the case definition that you would consider as symptomatic are approximately almost just slightly under 70%. The rest did not meet the case definition, which means they're potentially symptomatic. The group that is symptomatic can be treated. However, for transmission, for understanding transmission, that group that is asymptomatic is actually a very important group because they perpetuate transmission within the community, in together with post-Kala-azar dermal leishmaniasis, and then those who have a relapse. So it's important for us to take note of the asymptomatic group because they have a role in transmission. And if we are going to work towards elimination and towards reducing our incidence, our monthly or yearly incidence, we need to think of ways by which we can get this asymptomatic group because they do contribute, and I'll show you what we've done in the model. The other graph basically just shows you what tests are used. We use the RDT test most commonly in Kenya. The sensitivity for that, especially if combined with case definition, is pretty high, especially for those who are symptomatic, but it's pretty low for those who are asymptomatic. We have parasitology and we have the DATs that go on. The graph below basically just shows from the data set we got what was the occupation for the people. Animal herders, majority did not list it, but animal herders are kind of the highest. Then we have students and we have self-employed. The herders part is actually important because they spend more time outside and potentially get more bites. Important thing to remember here is the ecology of the vector. There is indoor biting and there is outdoor biting. We could easily do residual spraying and nets within the indoor environment. However, we need to think about what does the external outside environment, outside the house. In places with a manyatta, that there are livestock, that there are dogs, there are hyraxes, how do we have an integrated environment vector management program to work with? This just gives you a picture of cases by age category. Important to note here is approximately 60% of VL cases in Kenya, 66% of VL cases in Kenya are in males, and a huge majority of the cases as well, about 65, 66%, are actually in children under the age of 14. Here, you're seeing that children under the age of 2 account for about 20%. Children between 2 to 5 account for about 17%. This categorization is important because it allows us to think about, number one, where do they get infected? We know children under 2 are basically within the household or around the household, which gives an indication of potentially they get infected around that particular household, which brings into question, as an extra layer of thinking, what kind of interventions could we use? Important to note also is we see a lot of cases in those who start kind of participating in household chores, especially grazing, 5 to 15 years old, and also in 15 to 24 years old. This is a case, here we're basically showcasing the case fatality, and we see a very high case fatality in under 2s, about 3.3%, but also in those who are above 45 years old and 24 to 44 years old. One thing we've noticed, especially in the epidemiology of visceral leishmaniasis in Kenya, is the concomitant diseases. So tuberculosis, more specifically malnutrition with a very high case fatality rate, but also in HIV-infected individuals, especially those between the ages of 24 and 44. That is mainly driven by concomitant diseases. Those above 45 as well is mainly driven by concomitant diseases, so comorbidities. But in the younger children, there's need to rethink through, especially the treatment regime we are giving. In terms of clinical presentation, and this is critical, especially for those who do clinical diagnosis and also those of us who work in the wild, for instance, the Kenya Defense guys or the KWS guys who may be working in certain areas. The clinical presentation here, fever was the highest. As usual, the case definition is fever plus hepatomegaly or splenomegaly. 88% had a fever. Fever plus splenomegaly or hepatomegaly was about 63%, which means our case definition by itself does capture about 63% of the cases. That is something to think about because it means we have about 37% that do not meet the case definition, but they need to be considered because we've seen from the previous slides that the asymptomatic are actually important, and we'll show just in a short while what it means to have asymptomatic in the population. Just spleen alone is 61.5%, which means a lot of our cases actually do come in with splenomegaly. Liver hepatomegaly is only 18%. This is critical because in certain countries like Ethiopia, the case presentation at clinics is very different from what we have as a clinical definition here. Our commonly used drugs are the SSG and the paramomycin. We also have ambison. Occasionally, in the absence of the combined therapy, we use SSG alone, but we have the glutathione and some others in between there. So now that we're done with the elimination, let's spend the next 10, 15 minutes kind of exploring a little bit of how do we layer the elimination. So we've seen high burden counties and low burden counties. And we could think about like, hey, what if we have counties that are at an incidence of more than 15 per 10,000? That is the dark red line towards the notes in there. And those are cases where we can say those counties need emergency kind of planning. We also have kind of like a control phase. We can classify them into like control phase, where we talk about at least about 5 cases, but below 15. Then we have low endemic, 3 cases that are an incidence, 3 per 10,000. And then we have what we could consider as an elimination. Once a disease goes below less than 1 per 10,000, potentially you could eliminate it. That is the dotted red line on the far end near the names of the counties. What this graph is aimed to show is we could think about who are the elimination candidates, who are supposed to be in the control phases, and who are in the high burden category. If our aim, and this is a conversation we've been having, especially with different partners, if our aim is to go below less than 1 per 10,000, then we have a long way to go. However, we could face it or cascade it in such a way that we have different counties and sub-counties or wards at different space. And that means we work on one area after the other. This is a similar graph, but then it shows you which sub-counties are actually at the emergency. And I think there are about 20 of them, starting from Aro in Turkana all the way to Lysamis up there. And we could use the same thought process for at what point do we define elimination, who will be considered as low endemic, who is in a control phase, and who is in emergency phase. Because all this classification means we have to approach them differently. And so in doing this analysis and thinking about elimination, what are some of the epidemiological insights that an implementer or a ministry would want to have? One is hotspots, which you're targeting high-risk areas. Second one is understanding the variation at this county, sub-county, or ward levels, basically to guide specific interventions. The third is optimizing resources distribution. It takes about 17 days to actually treat an individual within a hospital. And so you will find that as much as we have like 84% treatment completion rates, we still have a lot to think about. And then thinking about local elimination feasibilities. And so we built a model here that we are trying to look at the transmission dynamics and potential control strategies. And so we have a susceptible, exposed, infected, and recovered model, mechanistic model, that has an extra components, including the asymptomatic but are infectious, and symptomatic and are infectious. And then we have a dormant, which is basically pre-PKDL, which is the post-Kala-azar dermal leishmaniasis. And then we have another extra compartment for the post-Kala-azar dermal leishmaniasis. We also have vector components and the temperature dependencies. From that particular model, we see that at a national level, our reproductive number, this is defined as the secondary number of infections that one infected individual, when introduced into a community, into a naive community, in other words, a completely immune community, how many extra cases, secondary cases, would they cause? And we see our R naught as 4.87. However, the thing to remember here is graph B, the relative contribution to transmission. From our modeling, PKDL contributes about 10.2% of the transmission. Symptomatic cases, that is cases that meet case definition. Case definition in Kenya is fever of more than 2 weeks plus hepatomegaly or splenomegaly, is only about 20%. The vast chunk from our modeling, the vast chunk of infections are actually driven by the asymptomatic individuals. That is about 70%. When you go to graph C, it talks about the hidden burden, and we have 89% being asymptomatic and only about 11% being symptomatic. That is very concerning because ideally what we are using to look at here are people who presented themselves to a health facility. We haven't really considered those who are in the community, which constitute approximately the 89%. Underreporting, basically we looked at from the model those that are reported vis-a-vis the one that model calculated, and we have about 47% of underreporting. The thing to take out of this is we have a very high transmission. A disease needs to be less than 1 in terms of the basic reproductive number for it to die out or for you to be able to control it. If it's more than 1 means if it's 2, then it means an individual is able to infect 2 other individuals, whether it's animal or humans. So at a 4.87 is a very high transmission. 89% of infections are asymptomatic. And it's important to keep this group in mind because our goal of working towards elimination is highly dependent on identifying these individuals or capturing these individuals and taking them out of the transmission cycle. Asymptomatic are driving about 70% of the transmission, and we have about 47% of underreporting. In terms of strategies for control, we explored treatment only, ITN only, so the treated nets only, or ITN and the indoor residual spraying, or an integrated model, which allows us to both have and included all those plus environment vector management. And what you see here is on the x-axis of graph A, we are talking about a controlled reduction in a controlled reproduction number. So basically the controlled, if we play around with the interventions at a certain coverage and at a certain efficacy level. And what we see is if our coverage is about 40%,
20, 40, 60, 80, and then it reduce.
If our coverage is about 40%, we see that treatment only does not do very well. Integrated still does well, but we still have an R naught of about 1.8. If our intervention coverage is about 60%, we have a reduction just using treatment alone. But if we think about ITN alone or ITN plus IRS, we start seeing a drop in the infections, the transmission. However, when we move to about 85%, then we see a reduction, especially with the integrated model, of the R naught to about 1.53. And so here we basically on graph B, we are basically showcasing intervention coverage and R naught as a function, and basically showing that treatment only may try to reduce it, but it won't. However, the other ones, ITN only, ITN plus IRS, but integrated does perform better. To basically kind of blow that out, excuse me. To basically blow that out, in terms of looking at projections between 2025 as the base year up to 2030, we see that at 20% coverage, the R naught is still about 2, and we have about 4,700 cases. Might be a reduction, but not a significant one. But then as we move along to 80%, we're actually able to reduce the R naught, but then we have about a 50% reduction. What the graph basically shows you there is projected number of cases over the next about 10 years is about 25,000 total cases over the next 10 years. And we could be able to reduce that by 50% if we are able to actually have an integrated model. And the graph below just shows you the monthly incidence trajectories with a reduction. This is kind of just a blown up 5-year projection with monthly incidence coverage. And then, we see that with the ITN, we are actually able to reduce cases to about 4,000. And so the thought process around here is we have the baseline where R naught is 4.8, and then we have cascaded coverages based on what kind of coverage we have. What we are getting from this is we will need to sustain at least a 60 to 80% coverage over about more than 5 years to be able to bring down the cases significantly. If we look at cumulative cases over 5 years and cases averted, graph B, so graph A basically shows you the cumulative cases of about 5 years, and we see that over the 5 years, we actually, at baseline, we are hitting a very high number. However, and by baseline, when we talk about a 10-year projection, I'm just showing 5 years. When we talk about a 10-year projection, we're looking at about 25,000 cases. Here, we are looking at something in the range of about 8,000. The confidence interval goes to about 10, 11,000. However, if you think about kind of like coverages, 80% coverage, 60 to 80% coverages start giving us a very good reduction in numbers. And that also translates, obviously, to what cases are averted that could be translated into the cost-effective analysis. So, sorry, the graph is merged up, but the integrated one gives you about a 50% to 54% kind of reduction. This graph basically is to show you how the intervention coverage is vis-a-vis the efficacy coverage, just like the previous one, but just in a more clearer version with some standard error. The green shade below is kind of our elimination zone when we are thinking about if we have cases below 1 per 10,000 as an incidence, then we're actually able to start talking about that. But then you'll see that within the 5 years, we are not able to get there. So what does the program talk about? They talk about a planning phase, an attack phase, a consolidation phase, and a maintenance phase. Considering that we have different levels of wards or sub-counties, depending on how we approach it, it means some are in different phases. And that means they'll need to be, as the current elimination strategy that has just been launched talks about, kind of a cascaded response. And so we may think about priority interventions by geographic strata, where we talk about like high burden wards, having biannual active case detections, IRS, that's the indoor residual spraying, diagnostic to be able to capture as many as possible, especially the asymptomatics, integrated nutrition services, considering that malnutrition is actually a big comorbidity, and then vector surveillance. We could talk about maybe the moderate burden counties, talking about case finding. So, and there's definitions for what case finding is: targeted vector control, community health worker training, strengthened diagnostics, and health education campaigns. And then in the low burden, to ensure that we do not have an accumulation of cases, have a well-structured passive surveillance. We could have a maintain the same treatment capacity, however, have a plan for outbreak preparedness, and more importantly, cross-border coordination and annual health worker refreshers. So based on our modeling and seeing how the wards and the sub-counties are classified and noticing the fact that number one, malnutrition or comorbidities are a problem, but also the incidences are an issue, and we need to divide the wards or whatever administrative unit we use into different categories to allow us to think through the different modalities of interventions. Then we think about like how can we cascade indicators, ward level incidence, number of wards achieving less than 10, and actually we can go down to less than, because we know we have the high burden being really high, so we can start by bringing them down to 10 and then to 5 and then to 3. Case fatality rate as part of what we're targeting being less than 1%. Geographic concentration. A good chunk of that comes from process indicators. Active case detection coverage, treatment completion rate. Right now we have about 84%. We need to go to above 90% to align with the WHO protocols. The other thing before moving from that is we need to have people attending clinic or getting into the health facility within 30 days of symptom. Right now, approximately 70% of patients we have are able to actually get that, but 24.5% are not. They actually do present to the facilities more than 30 days. And so then the question becomes, how much do they contribute to the current transmission? And that might be an issue with SBCC, social behavior change communication, but also other aspects. HIV testing rate, the target should be 100%. Our target rate, especially from the data we have, is a very low testing rate. And we know those who have HIV have a very different presentation, but also more importantly, their management is different. 6-month follow-up, post-completion, IRS or ITN and the integrated coverages, and then having Sunfly in sentinel sites from basically the maps we were showing you about the villages or the wards, being able to identify certain particular areas, because then it will allow us to actually even be able to estimate transmissions just from them. So from this analysis, what are the conclusions we can draw? Number one is we have a couple of high burden wards that account for about 60% of the cases, and about 18 of them account for about 47%. So these are actually the pathway to elimination. If we are to focus on them, where we think about high burden sub-counties or wards that also have an upward trend. Here I've listed sub-counties. In terms of counties, we can talk about certain high burden counties: Turkana, Wajir, West Pokot, Baringo, the Manderas, have the largest number of sub-counties with concerning trends. In other words, here is upward trend. So where upward trend means over the last 3 years, do they have cases reducing or cases increasing? And for most of those sub-counties, the cases are increasing when you do a trend line. Mandera, Isiolo, Baringo, Marsabit. So the important thing to remember is county level analysis does mask the epidemiological gradient at the sub-county or ward level, and the analysis mainly, especially as a targeted centered more on the ward levels. In terms of interventions, we need to think about a phased and a cascaded response encompassing integrated management of the vectors, the patient, and the environment. Identifying hotspots allows us to actually be able to do targeted vector surveillances. Understanding the patient category and the situation analysis that we've just given, including the comorbidities, the treatment, and the outcomes in terms of death. Our case fatality rate overall is low, but it has been increasing over the last few years with a peak in 2025 of almost, I think, 3.4. And so we need to have cascaded interventions to allow for optimizing of resources based on the burden. But then there's a flip thought there. It does not mean that the low burden wards should not be given priority. They need to be given priority, but with targeted surveillance mechanism for them not to be an emerging foci later. In terms of the modeling, the future projections, we are looking at a baseline of about 8,000 to 10,000 cases in the next 5 years and about 25,000 over the next 10 years. if no interventions. However, with about 80% coverage, we have about a 50% reduction. However, in all our scenarios that we were looking at, coverage levels from 20 all the way to 80%, we still have our basic reproductive number at greater than 1, which means that that will not allow us to achieve elimination. For us to get to at least lower than 1, we need to sustain a 90% coverage. Excuse me. We need to have a 90% coverage that is sustained at least 5 to 10 years. The other thing to consider is 89% of our cases in Kenya are asymptomatics, which means they are a silent reservoir and they contribute to transmission. 70% of our transmission from our modeling shows that it's coming from the asymptomatic group, which means we need to think about how we can design surveillance programs to be able to capture the asymptomatics so that we can actually dent the incidence. By 2030, with 60 to 80% coverage, we will not have eliminated visceral leishmaniasis. The reproductive number, especially the controlled one, is still 1.6 to 1.8. It's greater than 1. We will have done something, but it's still greater than 1. If we strongly have a strong control, we have a 50% reduction vis-a-vis a baseline. That is at about 85%. We need to go higher. Monthly incidences might be down with 60 to 20% coverages to about 57 to 70, down from what we have now as 138. And we will have laid the foundation to push for elimination at least 2030, 2035. So what is our path to elimination? I'm putting there in brackets post 2030 because that is what the model is giving us. Increase the coverage to at least 90%. Maintain that for about 5 to 10 years. Consider additional strategies. More important strategy here is how do we get the asymptomatic group, but also more importantly, how do we have an integrated environment and vector management. And then we can now plan for an elimination of about 2030 or 2035 and a post-certification following the WHO criteria. So the bottom line from this work and from this presentation is VL elimination in Kenya is very achievable, very, very achievable. However, 60 to 80% of strong control by 2030, at least more than 90% coverage sustained for about 10 years for elimination, have an integrated strategy, especially ITN, IRS, environment vector management, and treatment. And that means cascading the treatment to be able to also capture those who are lost to follow-up. And then have a long-term commitment as a country that, as we have seen in the recently developed elimination strategy by the Minister of Health, that goes thinking more beyond what would be the 2030 WHO targets that they've given. And that represents the end of my presentation. We have a lot of partners, including the Minister of Health, the End Fund, the Gates Foundation, AMREF, ICIPE, there's KEMRI and others. Apologies if I've left out your emblem or a logo. Thank you so much. And I welcome any questions.
Thank you. Thank you so much, Dr. Omondi, for the brilliant presentation. And it's always fascinating how modeling can transform how we allocate resources for surveillance and also targeted interventions. So we enter the Q&A session now and ask you to continue posting your questions on the chat, or you can raise your hand. But we already have some. One from Pascal Juma, who is saying, wonderful presentation. What's the level of awareness among the affected population on the conservative insect, the sandflies? What prevention measures are currently in place on vector control? Can the affected communities be helped through organized vector control interventions by private pest control operators?
Okay, lots of questions in one. So Pascal, thank you for that question. Number one, there has been a lot of work, especially by the Minister of Health, towards social behavior change communication. mainly to create awareness within the communities. So there is some level of awareness within the communities, especially the affected communities, but we need to increase the levels and have it as an integrated measure in together with supporting, especially the case finding, more importantly for the finding their symptomatics. With respect to private individuals, I think here it's more of thinking innovatively. If I was to think through it, I would say we still do, as Minister of Health does a lot of vector management and a lot of integrated management. However, there is an element that is needed to basically be able to combine that with SBCC. VL is transmitted by the phlebotomine, female phlebotomine, that tend to live in termite mounds, in vertisols, but more importantly also around households. The manyatas in cracks in houses, there's an element of dung from the cattle that are kept. There's also the element from our perspective, especially as integration between human and animal health. There's need to be able to think through an integrated disease surveillance and response, especially for the reservoirs. We have not seen, there's some work done by the Kemri team, Dr. Matoke and others, Dr. Masiga, Tisipe and others, especially in identifying blood meals from the phlebotomers. But I think the vet side as well, or the animal health side as well, needs to come in and also do a lot of surveillance, especially in the animals, to identify potential reservoirs, because that will help us kind of dent it. In terms of how the private sector vets may play, I think that is up for debate, because it means either working together with the Ministry of Health and together with the Ministry of Agriculture and Livestock Development to basically identify strategies that could be used to basically manage the vectors. At the top of my head, I can't really say how the private vets will come in, because most of this work is currently being done by the Ministry of Health. Thank you. Hope I've answered it.
Okay, Pascal, I hope your questions have been answered, all of them. The next one is by Grace Maina. Is Leishmania clinical testing and diagnosis a routine thing in areas where it keeps happening? Are the facilities well equipped for this?
Yes, there are treatment facilities and diagnostic facilities, and they have been increasing in numbers over the last few years, courtesy of partners that we have. In terms of the tests, we know the RDT is not necessarily the best. It does not have very good sensitivity. Sensitivity here is the probability of a test being positive given that you have a disease. So in other words, identifying a true diseased individual, and the specificity is also a problem. However, I think there's ways of increasing the sensitivity and specificity, especially in terms of considering the case definition and trying to ensure that you combine the case definition together with the testing. That will allow us. But then remember, in terms of it being routine, the test is used on those who are suspected of having visceral leishmaniasis, which means those who have met the case definition or have at least some symptoms based on the clinician's judgment. So it's not something that everybody who walks into a clinic in those particular endemic environments does get a test. No, it's only when you're suspected of having VL.
The other one is by Omaima, who is seeking clarification on the values used on the parameters and the model assumptions. And Omaima, if you want to clarify more, you can unmute and ask.
So just to kind of answer that particular question, we actually use our data, but also more importantly, we got values mainly from the literature and what has been done with the work with our partners to basically try and explore different parameters. We are refining the model, especially on the sensitivity analysis. And I think that will come up later as a publication as we work on it. But we can discuss more on the side.
Duncan, could you go ahead and ask your question, please?
Yeah, thank you. And thank you, George, for a very nice presentation. In fact, I was following up and I don't know whether I missed something. But anyway, it gives a good picture, but then the 10 years seem to be quite long. Mine was the two questions. One, we want to talk about the coverage, 60 to 80% or 80 to 90%. What do you mean by the coverage? Is it the treatment coverage, vector control coverage, SPC? What is that coverage? Because that is one. Then the second one is, have you looked at the impact of any specific intervention and see how much it contributes towards elimination? So, example, if you do one, only two combined or such things, so that you can see that for us to achieve or even to reduce the number of years that we need, then if you have this combination and then at this rate, it's going to be, it will lead us to elimination much faster, or it will, whatever information it will provide to us.
Okay, thank you so much, Duncan. When I talk about coverage, I mean coverage for, basically, I was combining, there's a treatment component to it separately, and then there is the vector management component to it separately. Now, it's important to remember that those two by themselves do not constitute kind of the complete management of a VL and complete management of VL in the country. In terms of cascading that particular thought process, I think as we explore more, especially with respect to, one, how efficacious are our treatment? How do we ensure, combined with treatment completion rates are at least above 90%, but also more importantly, targeting the asymptomatic within the community? Because right now, we haven't really looked at the impact of targeting the asymptomatic, which will actually bring us much more closer than 10 years to at least around, from the initial thought process, around 5 to 6 years. Not for elimination, but at least getting to a good level that now we can start talking about concerted effort in certain specific places to eliminate. In terms of exploring combined interventions, in this particular analysis, we looked at combinations of like IRS, ITN, but I think we might need to move further as we discuss amongst our partners within kind of the analyticals. What kind of interventions have we proposed, especially in the elimination strategy, and what do we see them in terms of having an impact and over what period of time? 10 years looks a long time, but remember, we still have 89% cases asymptomatic, contributing at least 70% of the cases we are seeing, which means up until we figure out how to actually have not just surveillance, but capturing the asymptomatic group, which seems to, from our model, contribute more to the infection. PKDL was only 10.2%. Symptomatic individuals was something in the range of 20-something percent. So up until we figure that out, we will still have the transmission going on. And so it's not just the interventions that we put in place, it's also getting the asymptomatic ones in place. But yes, 10 years looks like a longer period of time, especially the targets that we have. But the timeline can be brought forward, especially if we target surveillance, both for the patients and for the individuals, so the communities, and for the vectors. Hope I've answered.
Yeah, thank you.
Great. Another one by Grace Maina. You have mentioned that climate change and vector dynamics is shifting needed to cases being reported in new areas. What are the chances for missed diagnosis? Are the healthcare providers in these at-risk areas aware of what to look out for? Is there an active Leishmania surveillance in new risk areas, or the focus is on the endemic ones?
So there's a difference between a misdiagnosis and a missed case. From an epidemiological perspective, those two need to be separated. And I'll explain it this way. Number one, there's a lot of work that goes on, especially in terms of training healthcare workers in this country by different partners, including the Ministry of Health itself, in terms of building capacity. So in newer areas, especially if someone has traveled, because that's a big issue we are seeing, especially with the cases in the country, there might be a missed diagnosis, partly because it was not known. You may see the same thing maybe with those who are deployed outside the country and they come back, and that was not kind of something that's thought about. However, the bigger issue here is the missed cases, especially the communal cases. Now, in terms of handling the missed diagnosis, I think that is something that goes more into training of healthcare workers, but also more importantly into cascading the SBCC, the social behavior change communication, to areas that have similar ecological and niches. What I mean by that is this. One of the work that we are doing at SEMA is basically looking at ecological niche modeling, where we are trying to actually think about like which areas might be at risk of visceral leishmaniasis, and then trying to actually use that to develop risk maps that then can guide the Ministry of Health in terms of where to bring in the training. Climate change, yes, does play a role. We know obviously there's changes that are occurring, and we know it has been shifting over the last 30, 40 years. And that also means there are newer areas that we might start seeing cases. Narok is one of them, has very similar ecology to Kajiado, which has seen cases. Samburu is seeing cases now. Laikipia has very similar ecology to Samburu, so at some point we might expect cases to be there. One of the best ways of running these is doing surveillance over a period of time to basically understand the baseline level of the disease to allow us now to calibrate even some of these models much better. Hope I've answered your question.
Awesome. We have two, she had a follow-up. Is Leishmania clinic testing and diagnosis a routine thing in areas where it keeps happening? These facilities were equipped for this.
Yeah, we have 43 facilities in the country, at least more than 43%, 43 facilities in the country that are actually equipped both in terms of commodities, in terms of diagnostics, and in terms of management of these cases in different particular areas. They are mainly concentrated in endemic environments because that is where they are needed much more. However, their placement is actually driven by if they see higher number of cases, let's say in Kacheliba, they'll open one somewhere and stuff like that. So yes, the facilities are there and they're able to manage them. Do we need to increase them? I think that is something that as SEMA, we can advise on that as we start doing geographic accessibility and analysis to be able to kind of optimally talk about which areas are underserved based on now that we have geocoded data from the country. That is something we can obviously going to do as we move.
Omaima had a follow-up question too. How feasible is 80% or more intervention coverage in Kenya?
Good question.
George, can you hear me?
You can hear me? Yes. Good question. So it's always difficult to achieve 80%. However, when you have an integrated management system or an integrated model, you could reduce the coverage to a certain number, let's say 60%. That's why I kept talking about 60 to 80%. It's also important to think about how to dent, where do you get the transmission from? And as we start identifying where the transmission is coming from, then quickly we could actually target that, and it may have a bigger dent in the numbers than potentially others. So the 80% coverage might seem higher, and the need to go to 90% might seem higher. However, that percentage could come in lower, especially with targeted interventions and in targeted areas. So it doesn't have to be, it's not a blanket recommendation. That is why I started by classifying both counties, sub-counties, and wards into very high burden, moderate, low, and kind of non-endemic or less than 1 per 10,000 as an incidence. And so I think as discussions move on and strategies are aligned, there's need to cascade the thinking process in terms of what do you do in what kind of environment. And I think that's another extra layer of thought process that we can input as we move.
Last one by Mary Gichero. What is the role of the dog in elimination of VL, the predictions, especially with the increasing interaction with dogs?
Yeah, so L. tropica has been seen to be zoonotic and has been found in dogs, not just in Kenya, but also in other areas, especially like the Palestine-Israel area as well, and Morocco. As a country, we haven't really done surveillance in animals to identify which animals serve us reservoirs or potential reservoirs in this country. I know there's work done by Dr. Damaris Matoke at Kemri, where they've done blood meal analysis, but that is one layer. The second layer is basically being able to identify potential reservoirs within the sector. So if we want to control it, of course, we will have to do surveillance also in animals, because they have been shown in other areas to play a role, especially in other types of leishmania. With specific to visceral leishmaniasis, that is a potential hypothesis that is being explored currently.
Awesome. If there are no more questions, I think this marks the end of our session. And as we wrap up, it's clear that eliminating Kala-azar is not just a biological challenge, but a data and coordination challenge. Dr. Omondi, thank you so much for showing us how modeling provides the GPS for that journey. So attendees, thanks for joining us. Have a wonderful day, and let's continue towards working towards a VL-free Kenya. Thank you, and bye.